Well, welcome everybody. Today I'm going to be covering complex or what are sometimes called mixed acid-base disorders. So the concept here is that over the last few months we've covered the so-called simple or single acid-base disorders, but in the real world you may have more than one present. You could have one, two, three, or four present. So we're going to go through the thought process today as to how to determine whether you have more than one acid-base disorder present and also what those acid-base disorders are. So again, just to review what we talked about previously, we first look at the total CO2 or the bicarbonate and decide if it's decreased, normal, or increased. If it's decreased, you have one of three choices. It's either a metabolic acidosis, acute respiratory alkalosis, or chronic respiratory alkalosis. And remember, the PCO2 is down in all of them. So they directionally have a decreased bicarbonate and a decreased PCO2. And the way to distinguish them is we look at the change in the PCO2, comparing it to the change in bicarbonate, because each of them have a different ratio of the two. In a metabolic acidosis, the PCO2 falls 12 for every 10 fall on the bicarbonate. In acute respiratory alkalosis, it's 10 to 2. You can simplify these. You can make metabolic acidosis 1.2 if you want, or 5 to 1 for acute respiratory alkalosis, however you like to memorize it. I tend to like to keep the number 10 just because it's closer to the real world quantitatively. And in chronic respiratory alkalosis, for every 10 fall in the PCO2, the bicarbonate falls 3 more in addition to what it fell in the acute phase, so the total falls 5. And you can see these ratios are different, and that's how we distinguish each of these acid-base disorders. So for instance, in metabolic acidosis, as I said, for every 10 fall in the bicarbonate, we hyperventilate, so the PCO2 falls by 12. So for example, in a male, if the bicarbonate is 14, that means it fell by 10. So you'd expect the PCO2 to fall from 40 to 28. So the expected PCO2 would be 28. In the respiratory acid-base disorders, we have a temporal subdivision into acute or chronic because the bicarbonate keeps changing with time. So for a step change in the PCO2 here, we get an initial drop in the bicarbonate, which we call acute respiratory alkalosis. But if we keep measuring the bicarbonate in our patient, we'll find that it continues to fall until a new steady state is reached, and we call that chronic respiratory alkalosis. And that is a renal event and will only occur if you're not in CKD or don't have ESRD. So again, in acute respiratory alkalosis, for every 10 fall in the PCO2, the bicarbonate will fall by 2, or you can remember 5 to 1, or you can remember 20 to 4, whatever you like to remember. But the proportion is that the PCO2 falls 5 times what the bicarbonate falls in the units we use, of course. And the units for the PCO2, remember, are millimeters of mercury, and the bicarbonate is milliequivalents per liter. And if we keep hyperventilating the PCO2 at the same drop of 10, we find that the bicarbonate continues to fall further, so it falls a total of 5. And once it stops changing, we call that chronic respiratory alkalosis. We could also come to the patient and find the total CO2 is elevated, in which case, again, we have 3 choices. It's either metabolic alkalosis, acute respiratory acidosis, or chronic respiratory acidosis. And again, the PCO2 doesn't help you because it's increased in all 3 disorders. So we have an increase in bicarbonate and an increase in PCO2. So that doesn't help you. What helps you is that the proportion of the changes in each of these is again different. So in metabolic alkalosis, for every 10 increase in the bicarbonate, we decrease our ventilation such that the PCO2 increases by 7, or you can remember 5 to 3.5 or 20 to 14, whatever you feel is best. In an acute respiratory acidosis, the PCO2 is also elevated, but the bicarbonate goes up 1 for every 10 increase in the PCO2. And if we keep hypoventilating from the initial hypoventilatory response, we'll find that for the same change in the PCO2 of 10, the bicarb goes up another 2.5, so the total increase is 3.5. One of that was due to the acute effect, which again, remember, in the acute respiratory acidosis and alkalosis, this is all due to the bicarbonate buffer reaction shifting to the left or the right. The chronic phase requires renal physiologic events to occur. And again, remember, just like in respiratory alkalosis, you won't have this further 2.5 increase in the bicarbonate unless you don't have CKD or ESRD. So in metabolic alkalosis, no matter what the cause, let's say the bicarb went up by 10, you should hypoventilate. That's the ventilatory compensatory response, such that the PCO2 goes up by 7. So let's say it started at 24, the bicarb, and went to 34, which is a change of 10. The PCO2, if it started at 40, should go to 47. That would be called a compensated metabolic alkalosis. And in the respiratory acidosis direction, remember, for a step change in the PCO2, you get the initial change in bicarbonate due to the bicarbonate buffer reaction, which we call acute respiratory acidosis. But if we keep watching the patient, and if they don't have CKD or ESRD, the bicarb keeps going up further at the same PCO2. We're not changing the PCO2 until a new steady state is reached, and we call that chronic respiratory acidosis. So again, just to reiterate the rules, for a 10 increase in the PCO2, the bicarb goes up 1. And for a 10 increase in the PCO2 chronically, the bicarb goes up a total of 3.5. Remember that these changes take time. Metabolic acidosis, the ventilatory response, till it reaches its final level, takes half a day to a day. Metabolic alkalosis takes a bit longer. The chronic respiratory acidosis takes 3 to 5 days, and chronic respiratory alkalosis takes 2 to 3 days till a steady state is achieved. So there's some caveats that one needs to keep in mind when you're diagnosing complex acid-base disorders. And that what we're really talking about is, what if you come along and your patient doesn't have one of those 6 rules that we just described? Well, there's caveats associated with that. And it might be that you don't have a complex situation occurring. In other words, you have more than one acid-base disorder. It might mean that you're just not in a steady state. You haven't waited long enough to achieve a steady state, as we just talked about, and that's why you don't have one of the 6 rules. So you have to make sure you're in a steady state before you start thinking of mixed acid-base disorders. What came up last week is another caveat, and that is, what are the confidence limits? In other words, what is the range that we'll accept for these rules? And I'll show an example of that. And that's a complicated question because no one really has a good answer for that. When do you start deciding that what you see in your patient doesn't fit one of the 6 rules? Well, obviously, you have to have confidence limits around those ratios, which we just talked about, to know when it doesn't apply any longer. The other thing we're implicitly assuming, which people don't think about, is when we have more than one acid-base disorder present, we're assuming that those 6 rules that we've been talking about for months apply when you have more than one present. In other words, we know they apply in an isolated sense, but are they valid when you have multiple acid-base disorders present? And clinically, we assume that, yes, those individual rules apply even when you have mixed disorders. And unfortunately, that's been shown, at least in dogs, not to be true. It makes things much more complicated. The other concept, which we'll talk about in another talk, is something that Nick Medias, who unfortunately passed away not too long ago, found, and that is that the fall in bicarbonate in metabolic acidosis is not only due to the metabolic component. So in ketoacidosis, when you have a proton load, you drop your bicarbonate. But what he found is that the ventilatory response, or what we call the compensatory response, causes the bicarbonate to fall further. And that makes things very complicated, because if you think about that conceptually, a compensated metabolic acidosis really has 2 reasons for the fall in bicarbonate: the metabolic component and the ventilatory change, which makes the bicarb fall further. So if you want to go out on a limb, you can really say that a compensated metabolic acidosis is really not a simple acid-base disorder ever. And we'll talk about that difficult concept in another talk. So the first thing you have to make sure when you see a ratio in your patient that's not one of the 6, you have to rule out that you're not in a steady state. So let's look at this particular case. We have an 18-year-old male who was anxious. The PCO2 is 20 and the bicarb is 18. So when you look at those changes, you can see the PCO2 changed by 20, assuming it was 40 initially, and the bicarb fell by 6, assuming it was 24 initially. So we're left with one of these three possibilities. Remember, we look at the bicarb and it's down, so it's one of the three. And the ratios we'll write again for each. And then we ask the question, is the patient we just showed one of these three ratios? Well, if it was respiratory alkalosis and temporally between acute and chronic, you'll see why that's the case here. If it was acute, we would expect a change of 20. If the PCO2 fell by 20, the bicarb should have fallen by 4. And if it's chronic, if the PCO2 fell by 20, the bicarb should have changed by 10. But in our patient, the PCO2 changed by 20 and the bicarb changed by 6. So it's between these two. So the diagnosis is respiratory alkalosis, but the team just didn't wait long enough. Remember, it takes 2 to 3 days after the acute for this to occur here. So you caught the patient in between. Maybe this was after 1 day of hyperventilation. Now, if you first look at this, you may say it's a mixed disorder because it doesn't fit any of the 6 rules. But in fact, it's a simple disorder that you didn't wait long enough. So you weren't in a steady state. So just looking at this with time, if it was acute, the bicarb would be 20. After a day or so, it would be 18. And this time plot is exaggerated because remember I said that respiratory alkalosis takes 2 or 3 days to achieve a new steady state. This graph makes it look longer. And in chronic respiratory alkalosis, you would expect 14. So given those deltas of 4, 6, and 10, you can predict what the bicarbonate should be for each. And you can see that you caught the patient in between on the time course. The PCO2 isn't changing throughout, it's staying at 20. Here's another patient, an 18-year-old male who's unconscious. The PCO2 is 80 and the bicarb is 33. So first we calculate our changes from normality. The PCO2 went up by 40, the bicarb went up by 9, and the bicarb is in the up direction. So it's one of these three. It's either a metabolic alkalosis, acute or chronic respiratory acidosis. And here's the changes we would expect for each if it was a simple disorder. So if it's acute and the PCO2 changed by 40, we'd 10-to-1 ratio. Remember, we'd expect the bicarb to go up by 4. And if it's chronic, remember, it's 10 to 3.5 total. So we'd expect the bicarb, if the PCO2 increased 40 chronically, which means 3 to 5 days, the bicarb should be up 14 from its original level. And our patient had a change in bicarb of 9. So you can see, again, it's falling in between. And if you just look at these numbers simplistically, you would say, oh, it's not it's not acute or chronic. And it can't be metabolic alkalosis either. That wouldn't fit. So you would say it's a mixed disorder if you saw these. But again, the problem is you just haven't waited long enough. You caught the patient in between. And again, if we look at these numbers, acutely with the increase in PCO2 of 40, the bicarb would go up by 4. And in the chronic phase, it would be up so that the total level reaches a level of 38. But our patient had a bicarb of 33. So this just shows you that it really depends when you're taking the blood draws until you keep seeing 38. So once you reach 38, it just stays at 38 day after day, unless something else happens clinically. So again, don't get fooled into being in a non-steady state and think your patient has a mixed disorder. Here's another patient with an acute MI who's hypotensive. The PCO2 was 35 and the bicarb was 14. Anion gap is increased by 11. And the PCO2 changed by 5 and the bicarb fell by 10. So what's going on here? Again, we have a drop in bicarb, so it's one of the three. But our patient doesn't fit either of those. So you would say, oh, it's a mixed disorder. But again, the problem is a temporal one. Metabolic acidosis, remember, it takes half a day to a day for that PCO2 to fall to its new steady state level till the ventilatory response becomes complete. So in our patient, we had a PCO2 of 35 and a bicarb of 14. The PCO2 was down by 5, the bicarb down by 10. You would expect, had you waited long enough, the PCO2 would have fallen by 12. Remember, it's 12 for every fall on the bicarb of 10. Your as you see here, the patient's only changed by 5. So it fell over the next half a day to a day by a further 7. Initially, it was less than that because the team just didn't wait long enough. So it's, again, not that you have a mixed disorder. It's that you didn't wait long enough for the compensatory response to occur. So this is just an anion gap metabolic acidosis that's completely compensated appropriately by the 24th hour. Here, you just haven't waited. It's still an anion gap metabolic acidosis with incomplete compensation because the blood was drawn before the compensation was complete. Now, a question that came up in the previous talk was, when do you say that it's not one of the three? So, and that brings up the concept of confidence intervals, or what is the scatter in those ratios? And that was actually an excellent question. This just showed, and I had Leslie send you out some figures and some papers to look at if you want to get a feel for it, but it's quite remarkable. Here's data from Bushinsky's paper from years ago, where they just looked at a group of patients with metabolic acidosis and looked at the bicarbonate versus the PCO2. So you can see that for every bicarbonate here, there's quite a range of PCO2. So we say simplistically, it's a fall of 12 in the PCO2 for a fall of 10 in the bicarbonate, or the Winters formula would describe, and the best fit through this if you want to use that. But there's a scatter around here, and some people even go so far as to say that the PCO2 could be plus or minus 5 for any bicarbonate. I think that's a very large range and would make it almost impossible to diagnose a mixed disorder. But practically in the real world, we accept maybe plus or minus 1 for the PCO2, or at the most plus or minus 2. And this is an example of another paper. This is Newton's paper, where they defined the acute respiratory acidosis curve in humans, where they had the PCO2 increase acutely and looked at the bicarbonate. And remember, the rule is for every 10 increase in the PCO2, the bicarb goes up 1. This is all due to the bicarbonate buffer reaction. But again, you can see there's some scatter in the bicarbonates here for any, we say a change of 10 for a change of 1 here, but there is a range here. You can see at any bicarbonate, it's plus or minus 2 or 3 here. So again, we have this problem of these rules are an average of a population of people, and you don't know in your patient. You'll never know in your patient unless you had an experiment or a pure acid-base disorder to know what you're given, what your patient's ratio changes are going to be. So that is a problem. It makes the whole endeavor less precise than one would like it to be. But for an exam, they assume perfect precision. In the real world, it's more complicated because of the ranges here and here also. And then I'm just showing you 2 of them. All the primary acid-base disorders have this kind of scatter around a mean. Something else I mentioned was we implicitly assume that the acid-base rules apply when they're combined. So if we have, let's say, a patient with a metabolic acidosis who then develops a chronic respiratory acidosis, is the chronic respiratory acidosis rule still true? So let's say you have ketoacidosis and now you hypoventilate for 3 days. Is there going to be an increase in bicarbonate of 3.5 for every 10 increase in the PCO2? And it turns out that, at least in dogs, that's not true, that these acid-base rules change, and not all of them have been studied. There's a whole matrix of combinations you could create. But the ones that have been looked at, the rule does change when it's on the background of another acid-base disorder. And that, if you think about it, makes it extremely difficult to come up with a diagnosis, because basically you have to have a new rule for every combination. And each of them can change. Let's say you have a respiratory acidosis and alkalosis. In order to make the diagnosis, you're assuming always that the individual rules apply when they're combined. And at least in the dog, it's not been shown in humans. It's likely our biology is the same. The rules do change when they're combined, and that makes things more difficult in the real world. So it turns out that if you have in the dog, at least, if they have a metabolic acidosis and then they're hypoventilated, it turns out that the bicarbonate actually increases more than 3.5 for every 10 increase in the PCO2. The other thing that I wanted to mention, which I'll talk about more in another lecture, is the hybrid nature of the change in bicarbonate and metabolic acid-based disorders. So it turns out, and this is not recognized clinically, people don't talk or think about it, but it's been clearly shown, it's a fact of nature, that when you get an acid load and you get a decrease in bicarbonate because of it, and now you start hyperventilating as part of the ventilatory response, let's say it's ketoacidosis or whatever, the ventilatory compensatory response causes the bicarbonate to fall further. The kidney reacts as if you had a respiratory alkalosis, a chronic respiratory alkalosis. So it changes its physiology and drops the bicarb further. So when you come along and you see your patient with a compensated metabolic acidosis, the bicarbonate change isn't only due to the metabolic component. And there's ways we can figure out what those components are, but when you think about it, it means we always have a mixed disorder in metabolic acidosis that's compensated. It isn't physiologically or even philosophically a simple pure disorder. So we'll talk about that at another time. So how do we diagnose mixed disorders? Well, there's several clues and categories that you should think of that allow you to do this. The first is we take the change in the, if you see that the change in the anion gap, when you add that to the current bicarbonate you have, if that ends up being less than 23, 24, or greater than 23 or 24, you have a mixed disorder. So we go through this exercise, it's the so-called delta-delta, where we take the change in the anion gap in our patient. When we have an anion gap metabolic acidosis, this is something you should always do. You add it to the bicarbonate, and then you see whether you end up with a bicarbonate of 23 or 24. And if you do, then you just have a simple metabolic acidosis, anion gap type. But if your bicarb comes out less than or greater than, then you have another reason for the change in the bicarbonate, and you have to come up with that diagnosis. So that's one clue. The other is that you have normal acid-base numbers with an elevated anion gap. Third clue is that you have normal acid-base numbers with clinical causes of more than one acid-base disorder. So everything looks normal. The anion gap looks normal. Your acid-base numbers look normal. But you look at the patient and the clinical history and maybe part the physical also would cause you to think the patient must have more than one acid-base disorder present, or suggest that there might be one. So that's another scenario. We'll show examples of that. Then, if you have a lack of an appropriate ventilatory compensation in metabolic acid-base disorders, by definition, you have a mixed disorder. Or you could have a lack of appropriate renal response in chronic respiratory acid-base disorders, such as a patient with CKD or ESRD. You also have a mixed disorder. You could also have two categories of the same metabolic disorder. For instance, you could have a metabolic acidosis anion gap. You could have a patient with ketoacidosis who has diarrhea, and they have two reasons for their change in bicarbonate. It could be, in that particular scenario, the patient would have an anion gap metabolic acidosis and a non-gap metabolic acidosis. And we would call that a mixed disorder also, even though they're both metabolic acidosis. So let's go through each of these examples. So again, as I said, whenever you have an anion gap metabolic acidosis, you always should immediately add the change in the anion gap to the current bicarbonate and see if the bicarbonate ends up being normal when you go through that math. Now, why do we do that? Well, what we're doing when we do that is we're using the change in the anion gap as a surrogate for the proton load. And that it requires a lot of assumptions. So here, let's say as a patient with ketoacidosis who has a proton coming into the body with an anion from hepatic ketone body production or ketoacid production. Remember, the proton will drop the bicarbonate. The anions coming in will raise the anion gap. Now, in order to use the change in the anion gap as a surrogate for the proton load that came here, we're assuming that the change in the anion gap mathematically will exactly equal the fall in the bicarbonate. And that would make sense. Both of these are coming in at the same rate. Why wouldn't that be true? And the reason in the real world it may not be true is you're assuming the volume of distribution is the same. We're assuming that these both go into intracellularly and extracellularly into the same percentage of those two compartments. And that's not necessarily true. We're also assuming that the box is closed, that we don't have excretion of the anions in the urine, which is also an assumption, or that the kidney is not going to be compensating by generating new bicarbonate from glutamine. And so if you assume they have the same volume of distribution and you have a patient with ESRD who doesn't generate new bicarbonate and who doesn't excrete anions, then this assumption is valid. The change in the anion gap mathematically will be very close to the decrement in bicarbonate. So if you add the change in anion gap from normality to the current bicarbonate, you should end up with 23 or 24. The real world is more complex, but clinically people do this just because nephrologists like to do this sort of math. But in the back of your mind, when you do it, realize that if you don't get 23 or 24, it may be because of these other caveats. But anyway, when we go through the exercise, we use that to make a diagnosis of something else changing the bicarbonate if it isn't 23 or 24. So here's a patient who's on loop diuretic with ketoacidosis, and we look at these numbers. The PCO2 is 34, the bicarbonate's 19, the anion gap's up by 23. So if you just look at these two numbers, you would say the PCO2 fell by 6, the bicarb fell by 5. That's roughly a change of 1.2 to 1 or 12 to 10. You would say the patient has compensated metabolic acidosis, but going through this exercise, if we take the change in the anion gap and add it to the current bicarbonate, we get 42. So we have an anion gap elevation of 23, and when we add that to the current bicarbonate, we don't get 23 or 24. We end up with a number much, much higher than that, and we have to account for that. So if it wasn't for the metabolic acidosis, you would have an elevated bicarbonate still. So the metabolic acidosis is not bringing you back to 23 or 24. You're much, much higher than that. And so this would be an example of an anion gap metabolic acidosis and a metabolic alkalosis. And clinically, it makes sense, the patients on Lasix. Now, what if you have normal acid base? This will be a typical exam question. They like to give this, where you have a board question where you have normal acid base numbers with an elevated anion gap. So here you have a patient with ESRD who's vomiting. You look at the acid base numbers, everything looks normal, but the anion gap's elevated. So how can you have an elevated anion gap that was associated with anions coming in with a proton load, but you end up with a normal bicarbonate? Just intuitively, you know there must have been something raising the bicarbonate so that you're left with 25 despite the proton load. You couldn't have started at 25, or you would think that this would be, if the anion gaps changed by 8 and it started at 25, this would be 8 less. The fact that it's 25 despite the presence of the proton load and anion gap going up by 8, just without doing anything, you just have to think about it logically. This must have started greater than 25. So if you do the math and add the changes to each other, so even though it was 25, when you do add the change in anion gap, you end up with 33. So again, the reason you end up with 25 is because it was 33 minus something raising it to 33 and something dropping it by 8 left you with 25. So the anion gap metabolic acidosis dropped it by 8, and you would have to come to the conclusion that the patient has a metabolic alkalosis also, and that's why you ended up with two of these things resulting with a final number of 25, which on the face of it looks like it's normal, but you actually have two acid-base disorders, each opposite quantitatively in magnitude, leading, so the metabolic alkalosis raised it by 8, and the metabolic acidosis lowered it by 8, and you end up with 25. And again, you can't be sure that the elevation is due to metabolic alkalosis. It could be due to chronic respiratory acidosis also, which you would have to go into greater detail about. But there's no clinical evidence for that, and the patient was vomiting, so you have a clinical reason. So this would be a board question where you have normal numbers, your only clue is that the anion gap's elevated. And also, you have dysnatremia and hypokalemia too, which should be associated with some sort of acid-base disorder typically. Or you could have normal numbers with clinical causes of more than one acid-base disorder. So here we have a 28-year-old man with diarrhea and NG suction. So you would think this is going to give a non-GAP acidosis, and this is going to give a metabolic alkalosis. We have normal numbers. We have a normal anion gap. But we have dysnatremia and hypokalemia again. So when you see, if these were normal, you would maybe say that there's no acid-base disorder present and these are very mild. But the fact that you have these electrolyte abnormalities present tells you quantitatively it couldn't have been as subtle metabolically as you might think. And it's more logical to say these are normal because we have two compensatory factors here that are equal in magnitude and opposite in direction, leading to completely normal numbers. So that's really the clue that these are quantitatively important, and you can't just say, oh, the patient has no acid-base disorders. That would be a mistake. So this is, on the exam, you would pick non-GAP metabolic acidosis and metabolic alkalosis. The difference here is you don't have a clue that there's a metabolic acidosis because the anion gap's not elevated. So in a non-GAP acidosis, you really lose that clue. On an exam, they'll probably give you normal numbers with an elevated anion gap, like before. This is a more subtle question. Here's another case of a 32-year-old female, third trimester pregnancy, who was chronically ventilated, has normal numbers. Remember, the PCO2 and the bicarb in females are slightly lower. So these are normal numbers and nothing else that we can see here. But we have clinical reasons that we think something should be going on. Women who are pregnant have a chronic respiratory alkalosis, and these numbers are normal. So logically, you would think just from these clinical clues, the reason we don't see a chronic respiratory alkalosis is the patient's been ventilated and back to a PCO2 of normal, and therefore the bicarb is going to return to normal. So this is a young woman with a chronic respiratory alkalosis and a chronic respiratory acidosis that are equal in magnitude but opposite in direction. This coming from the pregnancy, this coming from the ventilation. And so she ends up with normal acid-base numbers. Now, another clue that you have a mixed disorder is the lack of the appropriate compensation in metabolic acid-base disorders. So remember, in the metabolic acid-base disorders, whether it's metabolic acidosis or metabolic alkalosis, we have a predictable ventilatory response that we call the compensation. And the thought here is that you should be predicting what that should be based on the simple acid-base rules of 12 to 10 for metabolic acidosis and 7 to 10 for metabolic alkalosis. And if it's, but the concept here is it's not sufficient to say my patient didn't compensate appropriately or there's lack of the expected compensation. When you say or find that in your patient the compensation isn't what it should be, by definition, you have another respiratory acid-base disorder in your patient. So it's not sufficient to say they have a metabolic acidosis that wasn't compensated. You're missing the next thought is that by definition means your patient has a problem with their ventilation and a respiratory acid-base disorder, either in the up or down direction. And I'll show some cases of that. So here's a 22-year-old male with testicular cancer who was anxious and on ifosfamide. Remember, ifosfamide can cause a severe proximal RTA. And the patient had a bicarb of 25 and a PCO2 bicarb of 15 and a PCO2 of 25, the anion gap was normal. So the PCO2 changed by 15 and the bicarb changed by 9. So remember the compensation in metabolic acidosis, the PCO for every 10 fall in the bicarb, the PCO2 should fall by 12. So in our patient, the bicarb fell by 9 and the PCO2 fell by 15. We would expect if this was a metabolic acidosis compensated, if the bicarb fell by 9, the PCO2 should have only fallen by 11, so that we end up again with a 12 to 10 ratio or 1.2 to 1 ratio, or the Winter's formula, if you like. This is what would be expected. Our patient's PCO2 fell more than one would expect. So the PCO2 should be 29, not 25. So if you have in metabolic acid-base disorders compensation which is not predicted, there is by definition, you must always remember there must be an additional respiratory acid-base disorder, and this is shown here. So our patient's PCO2 is 25, the expected is 29. So, and this is hard for some people to understand, but what this means is that everything above 29, and again, we're ignoring the confidence bands. There's some error here, but we'll just say everything above 29. In the real world, you would expect everything maybe above 31. Maybe plus or minus 2. But be that as it may, just for explanatory purposes, what the important teaching point is that everything above 29 in the red you call respiratory acidosis, and everything below 29 you call respiratory alkalosis. So this confuses people. They go, how can our patient have a respiratory acidosis if it's, let's say, 32 or 33 or 34, the PCO2? Isn't that only when the PCO2 is above around 40? And the answer is no. Respiratory acidosis is defined when the PCO2 is above what you'd expect it to be for that physiologic state. So if this patient has a bicarb, as we mentioned, you'd expect the PCO2 should be 25. The ratio is 12 to 10. But excuse me, it would be 29. The ratio would be 12 to 10, but it would not be 25, which is a greater change in the PCO2 than you'd expect. So this is an important thing to remember when you predict what the PCO2 should be in your patient with the ventilatory response. Everything above that prediction becomes respiratory acidosis, no matter what the absolute value of that number is. And everything below that becomes respiratory alkalosis. So in our patient, we expected 29 and we have 25. So the patient must also have a respiratory alkalosis. Had the PCO2 been 32, 33, 34, the patient would have also had a respiratory acidosis. So the answer here is a non-GAP metabolic acidosis and a respiratory alkalosis, likely from the anxiety the patient had. This is probably proximal RTA from the ifosfamide. Here's another case of a 35-year-old female suicide attempt with Tylenol, NG suction, and on a ventilator, and here are the numbers. So the PCO2 is normal and the bicarbonate's increased. So the delta PCO2 is 0 and the bicarb's gone up 12. So if this is a metabolic, this should be alkalosis, I'm sorry. If this is a metabolic alkalosis, the bicarb went up for every 10 increase in the bicarbonate, the PCO2 should go up by 7. So our patient, the bicarbonate went up by 12, and it's likely again from the NG suction, but the PCO2 didn't change. PCO2 should have gone up by 8, which would be a ratio of 7 to 10. So 8 to 12 is the same as 0.7 or 7 to 10. So the PCO2 should have been 46, should have changed by 8, start at 38 in a female. That would be the normal PCO2. So a delta of 8. So we should have seen numbers of 12 higher than normal for the bicarbonate and 8 higher for the PCO2. So the bicarb would have been 35 and the PCO2 of 46. But instead, we have a PCO2 of 0. So a delta of 0, excuse me. So the PCO2 here is 38. We would have expected 46. So again, it's the same thinking. We must have an additional respiratory acid-base disorder. Again, everything over 46 is respiratory acidosis. It's above what we expect, not above 40. And everything below 46 is respiratory alkalosis. So, and that again is confusing for people. If the PCO2, let's say in our patient was 43, that would be a respiratory alkalosis because the PCO2 should have been 46. That becomes the new level that you define respiratory acidosis and alkalosis from. That's your new floor. So our patient had a PCO2 of 38, and even though it's normal, it should have been 46. So it's below 46. So this patient had a metabolic alkalosis and a respiratory alkalosis. Now, the other possibility is the converse. We have a respiratory acid-base disorder, but the renal response is not what we would expect. And remember, we say chronic here because there's no renal response in the acute respiratory acid-base disorders. That's the bicarbonate buffer reaction. But if you have a patient with CKD or ESRD, you may not, depending on the severity of the CKD, and clearly in ESRD, you're not going to get the expected change in bicarbonate in the respiratory acid-base disorders. So here's a patient who's morbidly obese with chronic bronchitis, heart failure, and on Lasix. Bicarbonate's 34, the PCO2 is 35. And there are other clinical scenarios like this patient also where the change may not be as expected. So here we have the bicarb going up 10 and the PCO2 is going up 15 above its original level. So the patient has a PCO2 of 55 and a bicarb of 34. In chronic respiratory acidosis with COPD, remember it's 10 to 3.5. Our patient is 15 to 10, and we would have expected with an increase in PCO2 of 15, the bicarb should have gone up by 5. That's 15 to 5 is the same as 10 to 3.5. So we would have expected with the PCO2 increased by 15 that the bicarb should be 29, should have gone up by 5. It should not have gone up by 10. So the fact that it's higher than it should have been, given the chronic respiratory acidosis, means the patient also has a metabolic alkalosis. So it's a patient with COPD where the bicarb has an expected change of 10 to 3.5, and the bicarb went up higher than that expectation. So we can diagnose a metabolic alkalosis, especially with the patient on Lasix. We have clinical causes. Always backtrack and try to find the clinical cause of what your hypothesis is. Or we could have two categories of the same metabolic disorder. So here we have a 57-year-old female with a pancreatic fistula and ketoacidosis. We have a PCO2 of 16 and a bicarb of 5. The anion gap is increased by 7. So we have a delta PCO2 of 22 and a delta bicarbonate, both in the down direction of 18. So if we look just at the delta deltas, it works out to a compensated metabolic acidosis. A fall of 22 versus a fall of 18 is the same thing as a fall of 12 versus a fall of 10. So we can say for sure this patient has a compensated metabolic acidosis. But if you just stop there, you're going to miss an additional diagnosis because remember, we have an elevated anion gap and you always have to do that delta anion gap added to the bicarbonate to see whether you end up with 20 or 3 or 24 to know whether that anion gap metabolic acidosis can fully account for the drop in the bicarbonate. So when we do that in this patient, we add 7 and 5 and we get 12, which is not 23 or 24. So we know right away, given all the assumptions I talked about with this delta-delta calculation, the volume of distribution, the assumption there's no excretion and no generation of new bicarbonate. But given all those caveats, this tells you that the anion gap metabolic acidosis cannot account for the fall in the bicarbonate. The bicarbonate should only have fallen by 7. It should not have fallen by 18. So this tells you that there must be another cause for the fall in the bicarbonate concentration. So we can think of it this way, starting at 24, we should only have fallen by the amount that I showed here. And instead, we have this additional fall that the anion gap metabolic acidosis cannot account for. So if we add these two components, we can see that there's a change of 7 in the bicarb from the anion gap metabolic acidosis, but there's a further change of 12 due to something else. And in our patient, we have a good reason for it. We have a pancreatic fistula that causes a non-gap metabolic acidosis. Remember, pancreatic fluid has a very high bicarbonate concentration of about 120 millimolar or so. So when you lose pancreatic fluid, you're basically losing bicarbonate outside the body. So this patient has a anion gap metabolic acidosis due to the ketoacidosis and the pancreatic fistula causing the major decrement in bicarbonate, the non-gap metabolic acidosis. So two types of metabolic acidosis, even though it's a simple acid-base disorder of being a metabolic acidosis, because it's two subtypes, we call this a mixed acid-base disorder also. Now let's test your diagnostic skills. This is the last case. This patient actually has 3 acid-base disorders, and we'll just show how we go through the thought process. So it's a 14-year-old female with bulimia who's unresponsive, and an empty pill bottle was found. A little bit of hypernatremia, hypokalemia. Anion gap is up by 30. PCO2 is 22, and the bicarb is 13. So this is a change in PCO2 of 16 versus a change in bicarbonate of 10, both in the down direction. So when we add the change in anion gap to the current bicarbonate, we don't get 23 or 24. 30 plus 13 gives us 43. So the most common reason, given the clinical scenario, for the fact that the bicarbonate is much higher than just 23 or 24, independent of the anion gap metabolic acidosis. Remember, conceptually, what you're doing when you do this is you're saying, what is the bicarbonate in the absence of the anion gap metabolic acidosis? So that's why it should be 23 or 24 if it's the only disorder present. But if you end up with a number greater than 23 or 24, then in the absence of the anion gap metabolic acidosis, you have something else going on. So we have to account for why the bicarb is this high. No reason to expect chronic respiratory acidosis given the clinical scenario here. And especially since the patient can hyperventilate down to 22. So the most likely cause is metabolic alkalosis given the clinical scenario with the anion gap metabolic acidosis. But is that the only thing going on here? So that would account for the anion gap analysis with the bicarbonate. But what about the PCO2 versus the change in bicarbonate? We can't ignore that. So when we look at the PCO2 of 22, we have to think further. Remember, this is a great example of not ever looking at the pH, because the pH here is completely normal. And that's because the 3 acid-base disorders, even though they're in opposite directions, I haven't talked about the third yet, but quantitatively, each of them together, even though some of them are in opposite directions as far as the change in pH, they all just sum out to no effect at all. The net effect is no change in the proton concentration in blood. But if you just looked at that, you would not be able to make this mixed disorder diagnosis. So never look at the pH. Other than to be, it's interesting. You can tell the team that there's 3 acid-base disorders present, but they all cancel out when they're quantitatively all negating each other when you sum up the acidemic and alkalemic effects. So again, we look at the PCO2 and it's down by 16 versus a fall in bicarbonate of 10. And those are the numbers in our patient on top. The PCO2 is 22 and the bicarb is 13. If this was a compensated metabolic acidosis, we should have a change of 12 decrement for every fall of 10 in the bicarbonate. So we would have expected, given that our patient had a fall of 10, that the PCO2 only had fallen by 12, not by 16. So the PCO2 would be predicted to be 26. not 22. So the fact that it's 22 means, again, that we're dealing with the same sort of concept, that the expected PCO2 is 26. So everything above 26 becomes respiratory acidosis, and everything below 26 becomes respiratory alkalosis. So our patient also has a respiratory acid-base disorder. So the patient has a respiratory alkalosis in addition. The patient's hyperventilating to too great an extent. So this is an interesting case where you can diagnose the anion gap metabolic acidosis, but you have to do the delta equation, add the change in anion gap to change in bicarbonate to look at what the bicarb would have been in the absence of the anion gap metabolic acidosis. And that's how we can diagnose the metabolic alkalosis. But you still have to then look at what the delta PCO2 is for the delta bicarb in your patient. And if it's not what you predict for the compensatory response for the metabolic acidosis, then, or for the decrement and the bicarbonate, then you have to also come up with the respiratory acidosis disorder that's present. In this patient, the PCO2 was lower than one would predict given the expected ventilatory response. So the patient also has a respiratory alkalosis. Okay, so just reiterating the things you have to think about. Remember to rule out not being in a steady state before you start thinking of complex disorders. Remember, in anyone with an anion gap metabolic acidosis, to add the delta anion gap to the current bicarbonate and see whether it's 23 or 24 or less than or greater than, to know if there's another acid-base disorder present. Look for normal acid-base numbers with clinical causes of more than one acid-base disorder. Look for normal acid-base numbers with an elevated anion gap. Look for the lack of the appropriate compensation in the metabolic acid-base disorders in your patients like this last case, or look for the lack of appropriate renal responses in chronic respiratory acid-base disorders, or look for more than one category of the same acid-base disorder. Again, I didn't show it, but you could have a patient with Bartter syndrome who's vomiting. You could have a chloride sensitive and a chloride resistant metabolic alkalosis present in the same patient. That's also definitionally a mixed disorder. And we'll stop there today. So this is more complicated than the simple disorders, but just go through these case scenarios. The lectures will, online will be taped. And if you have any questions, please let me know. But this is sort of how you go through the thought process. And again, there are multiple approaches here, just because there's so many different conceptual reasons why you could have a mixed disorder. It's more complicated thought process than the simple disorders, but they will give you some of these on the board. So it's helpful to start getting used to going through these as quickly as you can, not just to be correct in your diagnosis, but to go through these numbers rapidly. And the best thing is just to practice a number of cases. And again, if any of you have questions or you want to talk about any of these ideas further, please feel free to reach out. We'll do it offline or by email, whichever you prefer. So thanks again for joining, everybody.